can probably get started. Thank you everyone for joining. And I see a lot of people have managed to join on the new link. We're running a webinar now as opposed to just a normal meeting, just because the number of people grew too much last week. So you'll see that there was a new registration process that needs to be followed. You will still need to complete the register at the end of the meeting so that you can get your CPD points. I'm going to also just ask that everyone please mute yourselves if you are not presenting. And just remember that this is a safe space with the intention to have really good conversation. Please put any comments that you would like to in the chat. These will be monitored and brought up as we go along. And if you feel like you want to share your voice, that's also really great. We are still waiting for ethics approval for this talk. I do think that it will happen, so I don't think it would be too much of a worry, but failing that, it'll just be normal CPD points. Yeah, our speaker today is going to be Gail. Gail's going to take us through some information around organ donation and prepping a patient, keeping a patient appropriately resuscitated for the best possible outcome in terms of organ donation. And then also just some of the ethics around organ donation in general. So we're going to hand over directly to Gail.
Morning, everyone. I don't know if you guys can hear me. I hope you can.
Yes, we can.
Okay. So, I have just a quick background. I have a background in transplant and organ donation. I was a transplant recipient coordinator for 4 years for the Netcare program here in Joburg. So, it was great with what I learned in that setting, and there's a lot of potential in the pre-hospital setting for identifying, number one, identifying potential donors, number two, optimizing those donors. And a lot has changed over in the last 10, 15 years in terms of organ donation, from where we were to where we're going. And hopefully today I can show you exactly how pre-hospital practitioners and pre-hospital providers can actually impact quite significantly on identifying potential donors, optimizing those donors, and actually increasing access to what we call the donor procurement pool. The biggest issue with organ donation is the paucity of available solid organs for patients. You're looking at probably sort of in the region for like kidney donations and then, or heart donations, you're looking at probably about 6,000 people per year looking for kidneys, and about maybe half of that amount actually getting the kidneys they require. For an example, the kidney cadaver waiting list in South Africa now is 10 years. If you do not have a related or unrelated living donor, you're going to wait about 10 years for a new kidney. And by that stage, there's a good possibility that you will actually no longer be a viable transplant recipient. So just to start off, some discussion points: you can donate, what can be donated, optimizing. I'm going to focus on optimizing the donor. And I'm going to take you through a few changes. This is one of the most significant changes we've seen in recent years, is donation after cardiac death. Previously, this wasn't thought possible because the organs were felt to be unsalvageable. With the onset of certain new treatment modalities and programs, this is actually becoming more and more possible. And in actual fact, it's increasing the donor pool quite significantly overseas. So we're not just looking at taking solid organs from patients who have been declared have suffered a neurological brain death. It's no longer referred to as brain stem death. It's neurological brain death. The process of brain death testing itself we'll do quickly, and then the procurement process I'll just go over with you quickly, and then we can open the discussion and open the floor. So who can donate an organ? Anyone can be an organ donor. And from birth to death. Studies have shown that most people over the age of about 60, we start seeing with solid organs, we start seeing that mortality and morbidity increase, and we have graft failures. However, there are still a number of other organs that are actually able to donate above that age. bone, skin, tissue, ligaments, corneas, all of which can be used not necessarily in saving lives, but impacting 75 to 100 other lives by donating bone and tissue and corneas. There are a couple of absolute contraindications to organ donation. Patients who have an active HIV infection that is uncontrolled by antiretrovirals or not on any antiretroviral treatment, their CD count, if it's over, I think, 1,300, they are not considered for organ donation. The flip side to that is we do have an active HIV recipient and organ donation program in South Africa. Predominantly currently focuses on kidneys. So patients who are HIV positive, who require a kidney, they have an extended criteria to be accepted onto the list. If they meet that extended criteria, they're put onto the list. We also have, we can actually take patients who are HIV positive so long as they meet extended criteria with regards to their CD4 counts and other criteria laid out by the South African Transplant Society and based on international guidelines. A number of transplant programs in the world have HIV transplant programs. So it is open to those patients if they require any kind of transplant. They just have to meet extended criteria. Patients with uncontrolled systemic sepsis that's not responded to any form of traditional treatment, any antibiotics, anything like that, their infection markers are still severely elevated. They are still indicating a severe infection with the causative organism. They will not be considered for organ transplantation because they will risk transmitting that causative organism over to the recipient. Bearing in mind, once the recipient is transplanted, they will be on immunosuppressive drugs for the rest of their life. So those organisms will run rampant in their system, and you will have a graft failure, and probably ultimately the recipient will also die as a result of that. Any type of metastatic or terminal malignancy, these patients are not considered for donation. For the same reason, your recipients will be on immunosuppressive medication. They will, the cancer will then take over within a lot shorter space of time and a lot more severely than they would have in the patient that the organs came from. From a recipient perspective, if patients have had cancer, if they are in remission for 5 years or longer, they will be considered for transplant. And then coagulation disorders, autoimmune diseases, and certain types of poisonings will be reviewed by the transplant team, and the risks versus benefit outweighed. If the poisoning has cleared the system, they can go ahead, they can use the organs. If it's not, if it's long-term damage, they will then outweigh the risk versus benefits in terms of transplant and consider those. Just a quick explanation of how the donor system in South Africa works. So South Africa works on what we call an opt-in system. This raises a big conversation that needs to be had. So an opt-in system is where you choose to be an organ donor. In South Africa, if something happens and you are declared neurologically brain dead, or you suffer from a circulatory death, and it is possible to donate your organs, your family is going to be asked, do they want to donate those? Do they want to donate your organs or not? They need to know what your wishes are. So this is the conversation you need to have with your family. You need to have with your friends. You need to open that door, open that conversation up. And this is a discussion that we can have completely, entirely separately to this. To educate people out there that there is an organ donor, there are multiple organ donor programs in South Africa. We've got very, very good checks and balances in place, and we will respect, however, the organ donor team will be called in. We will respect if the family chooses, for whatever reason they choose to say no to organ donation. We will respect that. We will still offer to work with the family and take them through the process of losing their loved one and what's going to happen and how it's going to happen and what they need. But we will not push the request for organ donation if they decline for whatever reasons they have. Europe and the US, particularly Spain, France, and the UK, have the most successful transplant programs in the world, as they work in an opt-out system. So opt-out systems are, when you're born, you are an organ donor. When you reach the age of 18, you can choose not to partake in that system any longer, so you opt out. You sign documentation to the effect, you make your family aware, so the system is aware that you've chosen not to donate your organs should something happen, and they will still approach the family after the fact and see how the family feels about it. But if you've chosen to opt out, they will not use you as an organ donor. Because these systems in Europe and the US and that are in place, they don't have a very high level of patients opting out. Most residents, most people living in those countries actually just stay within the fact that they're an organ donor. So no legal consent has to be obtained from any living relative or anything like that. They can go ahead and harvest the organs, procure the organs for organ donors that are on the list. And this also opens the door, particularly in Europe and the UK, for what I'll discuss a bit later on, called donation after circulatory death, because the same principles and ethical rules will apply. If the patient hasn't opted out, they've opted into the program, they don't have to obtain consent. They can just go ahead and harvest the organs as they see fit. In terms of South Africa, we can do related living donors or unrelated living donors if they match on a blood group incompatibility and an HLA, your human leukocyte antigen compatibility, for liver and kidneys. Liver, now they've moved towards what they call split liver transplants, particularly for pediatrics, so one parent can donate for a pediatric. The liver regenerates itself. It's the one organ that's known to regenerate itself. They will take the smaller lobe of the liver, transplant it into the kidney, and both the liver in the mom or in the parent and the kidney will then regenerate, and they will both go on successfully. The other advantage we have with liver transplants is they are the one organ that we can do an ABO incompatible transplant on. So if your recipient is a group O, blood group O in your ABO group, and your donor is a group A weak or A0, where they don't have a very strong protein marker indicated on the red cell for group A, they will actually tolerate being transplanted into a group O patient without an incompatibility, an ABO incompatibility graft failure reaction. And it has been done successfully without issue. South Africa, we're known for the first successful heart transplant by Prof. Chris Barnard many, many years ago, which started the transplant process in South Africa and actually started heart transplantation worldwide. We are also known for the first successful penile transplant by Prof. Andre van der Berg in Tygerberg in 2014. This brought about a significant change within South Africa itself and within a lot of African countries. With this, at the age of 16, a lot of young men undergo their transition into manhood. They undergo circumcision as part of their cultural heritage. And on occasion, it's been known that these circumcisions and this type of this rite of passage can go wrong, and they'll end up either being severely damaged or with a non-functioning organ. We now have successfully confirmed that we can do penile transplants, as strange as that sounds. The first patient that did have a penile transplant actually successfully went on to have children as well. So it was a success in more ways than one. He actually became a father after the transplant was done. And then in 2019, we had the first successful transplant. It's not taken from a person, but we had the first successful transplant of 3D bones, your saddles, your stapes, and your incus, in the middle ear by Prof. Chishifalara at the University of Pretoria to allow a patient to regain their hearing. So that opened a door there for us to actually, we don't only do cochlear implants now, but we can actually do middle ear transplants to allow patients to hear again and regain their hearing. So South Africa's had quite a few firsts in terms of transplant in terms of the transplant world as a whole, like we've done with many other things. We've also had successful firsts here in South Africa for other forms of transplantation. Organs that can be used for donation. Heart or heart valves. If we cannot find an appropriate donor, we can use lungs. Previously we could do what we call single lung transplants, and we could do split transplants where we do one lung into two separate recipients. However, that is shown to have an increased mortality and morbidity. They did go back to single lung transplants during COVID, which had a greater success rate. But the preference is bilateral lungs get transplanted, or we do lungs and heart, depending on if both are damaged from an underlying congenital cardiac defect. Liver transplants, as I said before, they can be split transplants or they can be whole liver transplants, and there can be an ABO incompatibility in terms of an A weak into a group O. South Africa, we do kidneys. Overseas, they've done kidneys, pancreas, intestines, and stomach transplants. Intestines is usually your small bowel, not your large bowel. They have also done successful transplants with a uterus, and I believe the first successful transplants in the US with a uterine transplant, the patient actually went on to successfully give a live birth after that. Postpartum, there is a program in place in South Africa from a tissue perspective to harvest the placenta, amniotic fluid, and umbilical cord. The placenta and amniotic fluid are harvested for wound healing processes for diabetic ulcers and decubitus ulcers on diabetic patients, as well as amniotic membrane can be used for eye injuries and eye damage to help healing of the eye and eye damage. And then the umbilical cord we can harvest stem cells from. A lot of hospitals, I know the NECI group does, they have a stem cell program where they will harvest stem cells for the baby and keep them stored. As I mentioned previously, we can do penile transplants. We will also harvest skin, bone, ligaments, tendons, and corneas if the family allow us to. And then we can harvest bone marrow stem cells and even blood vessels. Overseas, they can harvest limbs, hands, arms, feet, and there have been a few facial transplants done in France and the US where patients have had such severe facial damage that they've reconstructed the bone underneath, but then they haven't had sufficient skin, muscle, and fatty tissue to successfully complete the transplant. So they've actually found a donor that looks similar, and they've done facial transplants quite successfully. I think there's been about 3 or 4 of them done in the world in the last 15 or so years. For us as paramedics, we need to have a paradigm shift in how we think about patients that may be potential organ donors, how we identify patients that may be potential organ donors, and opening that conversation. It's not something that we've really done in the past, and we're in a good position to do it. We have first contact with a lot of these patients. You get to an accident scene, you can see isolated severe head injury with these, in these patients. So with the right training, the right education, the right backup, we can identify these patients early on. We can start optimizing their care pre-hospitally. They're not just an organ donor. So they just, the current thinking pre-hospitally, and you see a lot of pre-hospitally and even in hospital is, oh, well, they're an organ donor, put them in the corner, wait for the organ transplant team, see if the family will donate organs, and then we can move on from there, which is the wrong kind of thinking. These patients actually need to be aggressively resuscitated. They need to be as aggressively resuscitated within your scope of practice as a patient with a survivable outcome who's got the potential to walk out of the hospital. And there have been a few occasions where they've identified patients as potential organ donors. They've focused on aggressively resuscitating them, and they've had a successful outcome. The patient hasn't become an organ donor at the end of the day. They've actually walked out of hospital relatively neurologically intact. So we can also, with the right education, we can start opening up the conversation with the families. As scary a thought as that is, overseas studies have shown that paramedics are very hesitant to open the conversation because they don't know how. You're sitting in a situation where you've got a traumatic incident having occurred for the family, they're upset, they're shocked, a lot's going on. It is very difficult to open that door. Some families will come to you. I don't know if you've ever had it. I've had it once or twice where the family actually comes to you and they ask you, in terms of organ donation, what can we do? Can we do it? How do we do it? And in those days, I didn't know how to answer that question myself until I spent time on the transplant program. I was also kind of like, well, let's get him to hospital, speak to the treating doctor, and then we can activate the, they can discuss it with you and they can activate the organ donor team. Overseas research and overseas programs have shown that a lot of pre-hospital practitioners are willing to actually open that door. They want to know how to do it. They want to incorporate it into their care. They want to actually make it a part of what they do. And there has been a huge paradigm shift, I think, in pre-hospital care, realizing that we aren't just sort of pick up the patient, throw them in the back of an ambulance, drive to hospital. We are a large contribution to successful outcomes for that patient. And successful outcomes don't necessarily mean the patient is going to walk out of hospital alive. A successful outcome can be identifying a patient who is an organ donor, getting the family on board that train, getting them identified early as an organ donor, getting the proper resuscitation as an organ donor, and then, opening the conversation early with the family, and that patient going on to impact numerous lives because the family agreed to organ donation. Not all families are open to organ donation. Some families are closed to it. We will take a step back, let them think about it. We've had a number of cases where we've approached the family. They've initially been, no, I'm not interested. Then they come back to us and they go, yes, I am interested. So how do we optimize a potential organ donor? We treat them exactly the same way as they would have, as if you are treating a patient who would have a survivable outcome. We look at all aspects of patient care. I'll take you through how we can optimize a patient pre-hospital. I'll also take you through how they optimize them in ICU. From the beginning, if we start optimizing these patients from an organ donor perspective, from right in the beginning, we will allow the organ donor team, the organ procurement team, the transplant recipient team to be able to step into a patient where they have to do a minimal amount of work on that patient to get them to an optimal level for organ donation. So they will have to do less work, which means that it'll take them a shorter period of time to get everything in place to actually get this patient to the point where we can procure the organs, and they will be optimal organs that we can procure for the patient. We often have patients where they would have had optimal organs, but because they haven't been pre-hospital and in ICU, they haven't been successfully resuscitated appropriately, we'll end up with marginal organs, which has an impact on the transplant recipient in terms of their potential graft failure and potential delayed graft functioning. It takes them longer to recover. So it has a knock-on effect all the way through to the recipient at the end of the day. There are a lot of countries in the world, and we had some access to it a few years ago, where we could actually directly notify the organ procurement team and say to them, hey, listen, you know what, I've got this potential donor. We need to get back to that, where we actually, in a pre-hospital setting, we have access to the organ procurement teams and say to them, listen, I think I've identified a potential organ donor. I'm taking them to this hospital. Open the door, open the conversation. When you get to the hospital, speak to the doctor. The biggest impact this is going to have in terms of, I think the biggest impact this is going to have in terms of EMS systems developing a potential understanding is in what we call uncontrolled donation after circulatory death. So that is after the heart stops beating. And yes, we've reached a point in time where we actually can harvest solid organs after circulatory death, not just after neurological death. And it can be an out-of-hospital cardiac arrest situation. It can be an in-hospital cardiac arrest situation. We can identify these donors and we can actually get these organs procured to the point that we can actually even procure lungs and heart for the lungs and heart, despite ischemic cold times that we currently work with. So it's becoming very important for EMS to understand that they play a large role in potential organ donation and optimizing a donor. So how do we optimize a potential donor? Number one, don't work within your scope of practice and your clinical guidelines. I'll briefly outline what they do in ICU. A lot of you'll see what they do in ICU, the drugs that they use are not within your scope of practice, are not something that you can initiate pre-hospitally. So work within your scope of practice. It's important the biggest thing is maintaining the physiological stability during your treatment and transport. You will come across this in two different aspects. So you'll come across it pre-hospitally at the incident itself, where you have the initial insult, and then on occasion you may be required to actually move potential organ donors to a hospital where the organs can be procured. We cannot always do it at the hospital where the patient is at, so they will need to be moved. What you do from that hospital to the hospital where the organs can be appropriately procured is going to impact on the outcomes of those organs. So you can make a difference there by changing your strategy, by changing your treatment, and by opening the door to see if the referring hospital has actually instituted some of the treatment that is written out in South African guidelines for organ donation. Where you have, there are some of the drugs that the doctors can give ahead of time that will help stabilize the patient and will help you in transporting a more stabilized patient. So the goals that you're aiming for is keep a patient normotensive. If you need to aim for normotensive blood pressure, not too high, not too low. Sorry, someone got a question. You'll be aiming for normotensive blood pressure, standard MAP about 75 to 80. Your O2 sats within a normal range of about 94 to 98% on ventilation. Try and minimize your O2. Don't push it up to an FiO2 of 1. Try and minimize, drop your FiO2. Keep it so that you can mention, so that you can maintain your ETCO2 and your O2 sats within a normal range. Bearing in mind,
Azola, please mute.
Okay,
Azola, please mute.
Guys, please just mute yourselves if you're not listening.
so you're going to maintain sats within normal range, 94 to 98%. You're also going to target ETCO2 within normal range, 35 to 45 millimeters of mercury. Big thing to look at, you will see particularly with isolated head injuries and with patients with neurological brain death, they have a tendency to become hyperglycemic. Their humoral modulation and their neurohumoral modulation actually becomes significantly deranged after brainstem death, and it starts within 7 hours of brainstem death occurring. So this is where you're going to see, if you're transferring a patient, you're going to see this. I'll dive into it a bit. I'll dive into it shortly to what exactly happens to the body when that happens. So target normal glycemic ranges. Trauma patients, that kind of thing, sometimes this gets kind of left behind in the background. It's not the main focus. If you're going to be looking at patients like this, you're going to be optimizing them. Keep it in the back of your head, just do a quick HCT and target them to be normoglycemic. As per local resuscitation protocols, we've moved away from pumping through massive amounts of fluid into a patient pre-hospitally. We are starting to move towards HEM services and that, carrying blood products, particularly for your longer distance transfers. Use them if you've got them, use them if the patient needs them. Target away from anemia and to help maintain homeostasis. keep them at a normal, keep them above 36 degrees, normothermic, so 36 to 37 degrees, not too warm, not too cold. There's conflicting studies with regards to whether mild hypothermia has an effect or not. Some of the studies have shown that there is a delayed graft response, particularly with kidneys in patients who are mildly hypothermic, and there's a delayed graft response. So in other words, after the recipient has been transplanted, it takes a little while longer for the transplanted lungs to actually resume normal function if the donor was slightly hypothermic. So we aim for normothermia as well. Judicious use of fluid resuscitation, don't go overboard. Stay away from your Voluvens, and all of that kind of thing if you can. They are known to affect end organ function, and they are known to affect graft function once transplanted. In terms of ventilation, you are going to be ventilating the patient because they're not going to be breathing spontaneously. So aim for your standard appropriate lung protection ventilation, monitor your PEEP, monitor your peak airway pressure, keep it under 30 millimeters of mercury, your PEEP between 5 and 10. APRV is a good ventilation mode to use on these patients with what they call low stretch techniques to combat atelectasis or areas of atelectasis or areas of underventilation. Don't balance between underventilating and overventilating, so just ventilate them appropriately. Fortunately, a lot of the transport ventilators we have today, it's not like the old days where you sort of had a tidal volume and a rate. Nowadays, the transport ventilators give us a lot more, so we can do appropriate lung protective ventilation on your patients. These type of lungs, because of the way brain death occurs, these type of lungs are very, very sensitive to ventilation changes and to fluids. There was always a debate between the cardiothoracic team that did the heart and lungs and what we used to call the abdominal team, the team that does the kidneys and the liver. The abdominal team will always push fluids, flush the patient, get everything out. They need to be significantly liberal, give them lots of fluids, flush it all out. The cardiothoracic team would be exactly the opposite, say run the patient slightly dry. Studies done in Spain and in Europe actually indicated that overall, if we ran judicious fluids and we maintained, instead of over or under fluid resuscitating them, if we maintained a homeostasis with fluid resuscitation, they not only had better graft outcomes in terms of they were targeting lungs and heart when they did the study, but they actually, as a side-on, found out that liver and other organs actually benefited from judicious fluid use just as much as the heart and lungs did. And they had a massive, quite a significant decrease in graft failure, in end organ graft failure for the recipients, and mortality and morbidity for the recipients. So overall, it was actually proven that judicious fluid use is a good place to go for all solid organs, not just the heart and lungs. Don't withhold any pain management from these patients, paralytics or sedation. It won't affect the eventual outcome if the patient is if they do become an organ donor, if they are declared brainstem dead. Don't withhold that at all. Do give appropriate pain management, appropriate paralytics if you are seeing any kind of reaction, appropriate sedation. It does, if you withhold it, you do see a catecholamine release even in a brainstem dead patient or a patient who's on the verge. They're not quite brainstem dead yet, but they're pretty much there due to their brain injury. You do see a stress response with them. You see an increase in cortisol. You see an increase in catecholamines. It does have a profound effect on end organ function at the end of the day. So please don't withhold any kind of pain management from these patients, paralytics or sedation. Use your normal doses that you would use. Make sure that they are pain-free, make sure that they are, so that you can ventilate them appropriately, keep them normothermic, keep their SATC, ETCO2 within normal range. It's vitally important that you do that. Also, don't withhold the use if you've got vasopressors or you got access to vasopressors, or if they started, or inotropes to maintain a normotensive blood pressure with your combination of your judicious use of fluids. If you're transferring from a hospital, they've started blood where you can, in terms of ALS transfers, these will be ALS or ECP transfers. Keep that blood going if you can. Try and avoid an anemic picture or the patient developing an anemia, so keep that going. Use vasopressors or inotropes, but use them judiciously with your lowest therapeutic levels that you can to maintain a relatively normal pulse and BP within the patient. Your adrenalines are obviously a bit harder. You'll see that the organ teams tend towards dopamine, dobutamine. Not really the right word, but your milder vasopressors or inotropes. Adrenaline is quite hardcore. We in the donor, the procurement team uses a very specific vasopressor to try and obtain homeostasis with potential donors. There's a number of reasons they use this. I'll go into this with you shortly. So just a quick stop here. Anybody got any questions? And the hand went up. So anyone got any questions at this point? Anyone got any comments?
Gail, there are quite a few questions in the chat group.
Okay.
I'm just trying to start where we are. I think the first one is from Anne Stain. So coming to the conversation, I don't have a filter, so it's an easy conversation to have with the curious. I try to have that conversation often. The more you chat, the easier it is to come up with your own dialogue. I can't do it when someone has just passed. That is up to my senior on scene, and most of them still quite young. I think the question there is, how do you go about it in a system where you are the junior on scene, if that's basically your skill set?
Yeah. It's, you know what, even as a senior, as a CCA, as a senior paramedic, coming up with a conversation like that is difficult. It doesn't, this doesn't matter. This conversation, it doesn't matter if you are BLS, ILS, ALS, ECA, ECP, ECT, even doctor. It's a difficult conversation. I don't think, for me personally, I understand where you're coming from in terms of you, the junior on scene, you've got an ALS paramedic on scene. This is not something that, Sandile, I'll come to you shortly. This is not something that is an easy conversation, regardless of your qualification. It is a hard conversation, which is one of the things I think we need to do as pre-hospital emergency care providers is say, we want to learn how to have these conversations. We want to learn how to initiate these conversations. We need that education and training. There have been studies overseas, and I saw Waldo made a comment about me talking. Thanks, Waldo. The UK has actually done a study and done research into what type of training and how keen pre-hospital providers are to initiate these conversations. And a lot of them are. This is exactly the point. They don't know how. How do you say to a family where you have a patient who has suffered a circulatory death or is potentially an organ, how do you approach the family and say to them, listen, I think you should consider organ donation? It's not, even I, having worked in the transplant division, having done this in the transplant division, it's not an easy conversation to have. And we need to have exposure in how to approach this, what to say, how we can say it. How do we open the conversation? I have had conversations where the families have come to me and said to me, look, I understand they're severely injured, they've got a severe head injury. Is there a potential that they're an organ donor, and how do we go about doing it? That makes it a lot easier when the family, actually someone in the family has that sort of, because they've obviously had that conversation, they've opened that door. The family's had that conversation, they've opened that door. Then it's a lot easier to say to them, look, let's get him to the hospital, let's see exactly what's going on. And we can broach the subject with the treating team, and they can access, a lot of the hospitals. I know Lenmed's got Netcare's got a trauma program, a donor program. Lenmed's got steps in place. I don't know if Cindy's on today. She's worked with Busamed. She's worked with she's now at Lenmed with their organ donor and transplant program. So she's also got a lot of experience with this on how to do it. And I think pre-hospitally, we need to open that door. We need to open that conversation. And we as pre-hospital providers need to say, right, I think my advice would be reach out to the organ donor teams, the organ procurement teams in your area and say, right, how do we help you guys get more organs? How do we open that door? How do we open that conversation? So I don't know, does that help, Anna Marie? Does that?
So that was Ang's question. I'm reading them for you from the chat. So I don't know if you can just access the chats and read the questions there.
I'm looking at some of them. There's quite a few. Yeah, SPOO, we do. Yeah, the US does what they call a walk of honor, where the staff, the hospital staff and the family will line the hallway. In South Africa, we do a donor pause. So we will do a donor pause in ICU with the family. And in theatre, we will do, a donor pause before we actually start the procurement process. And it's basically the same thing. It's paying an honor to the life lived and to what the family has chosen to do with in terms of saving other lives. So it's actually very powerful to be part of that process in theatre and in ICU with the family. It's a very powerful thing. Cecil, how do I go to work for to register for an organ donor? The biggest organ donor foundation in South Africa is actually the Organ Donor Foundation, ODF. You can find them on, Caleb posted the link there. You can find them, it's voluntary. Darren, it does make point of it. Within our transplant programs, I don't think we've ever done it actually. That where we've needed, where we've done that, where we've had where we've needed specific organs that we actually do truly want to harvest. If we can't get hold of family, then the patient will, the hospital will allow the patient to progress onto, to death as normal. This is something I think that could change with the onset of your donation after circulatory death and the impact that that could make. This would also change if South Africa moved from an opt-in system to an opt-out system, where if you were automatically an organ donor from the time of birth to about the age of 18, then you had an opt-out system, then we wouldn't actually need to approach the government. It would be similar to implied consent, treating an unconscious, that your implied consent under the Good Samaritan Act for an unconscious patient. I don't know if that answers that aspect of the question. We've never had it when I was in the transplant program, and to my knowledge, we've never done it that way, that we've highlighted specific organs that we need.
Perfect, thank you.
I just want to see if there's any other questions. Anna Marie, if you pick anything else up that I've missed, that would be great. Sandile, yeah, sorry, you had your hand up, and Tulani's got his hand. Hello, Tulani. Sandile.
Morning, everyone. Thank you. Thank you so much for this presentation. It's very important. I'm just trying to get my head around the cultural norms, especially in the African community. Even though some African families are now have been awoken to this type of thing where one has to donate some organs. However, the cultural norms, beliefs, religious differences play a huge role, meaning that one would have to really be good in reading the room before you even think of bringing up the subject.
Correct.
Otherwise, you might find yourself at the end of a feast or a nopkiri somewhere. So we really need to be as paramedics be sort of like given some form of a crash course on how to approach situations like this, because if we just go at it, blindly without any form of a guide that one has to work from, it might cause a lot of problems, because some families would say, yeah, you want to sell our family members' organs. You have a particular hospital or whoever. So it would be nice for paramedics to actually be given something to work from.
Yes.
I don't know if I'm making sense in what I'm saying here.
Sandile, you're actually
thank you so much.
Sandile, you're actually making perfect sense, because when I joined the program, ironically, at that point, we had actually started engaging with specifically, we are very aware of the cultural tradition component within the various cultural norms practiced by, the different sort of Xhosa, Zulu, all of that, and we've encountered, both on the recipient side and the donor side, we've encountered hurdles. In terms of I've had transplant recipients come in, and we've gone through the whole discussion with them, and they've said to us, look, I want to go home and I want to speak to my elders and my traditional healer, and to find out, can I do this, because I need to be buried with my organs so that my ancestors recognize me when I cross over, and they know it's me and they know who I am and I'm welcomed. And we respect that, and we give them we say to them, it's fine, they can go home. They can do what they need to do in terms of reaching out to their elders, reaching out to their traditional healers. Sadly, when I was in the program, unfortunately, we didn't see any of those patients return. I'm not too sure if the elders opted for them, advised them to not have organ transplantation, or if they unfortunately passed away and succumbed to the organ that was failing. But when I started in the program, I started in the transplant program in 2017. We were at that stage actively and are still actively engaging with the Traditional Healers Society of South Africa. They are very open to working with us in terms of reaching out to the greater community in terms of both organ donation and transplant for valid recipients. So the Transplant Society of South Africa is working with the traditional healers within the country to open those doors, to have those discussions with the communities, to approach them to say, there are ways that you can receive organs, you can donate organs, and we will be able to, when you cross over and you meet your ancestors and you're with them, you will be recognized, you will be seen, you will be and what you have done will be acknowledged, on the other side as well by your ancestors, that you've done something good for the world and for people. We have certain cultural beliefs. I stand corrected, and apologies if I'm incorrect in this. I think within the Zulu culture, your liver is believed to be a source of your courage. So a lot of Zulu people are very hesitant with regards to liver transplants, because they're concerned if they get a transplant from someone who is not as courageous as they are and considered to be a coward. So they're very hesitant to do things like that. So there are a lot of cultural boundaries that we need to overcome. As I said, we have engaged with traditional healers. We are engaging with them actively to open those doors in the communities. So for both, not just for organ donation, but for patients who require organs to be they transplant, they're valid recipients, that we can give them a better quality of life and extension of life if we do transplant an organ for them. So I don't know if that answers what you were.
There's another question for
Yes,
you
ma'am.
from
it does.
Lillian.
Yeah, I've got Liam's question. I'll come to it. I just see there's two hands, Tulani and Carl.
Okay.
Tulani.
Hi everyone. Hi Gil. Time.
Hi, young man.
Just basically, wow, young me still say that. Anyway, I just have two questions, and one of them is based on my experience at Netcare 911, where we used to do we used to transport organs. And
Yes.
I hated those cases because they usually came at 2 o'clock in the morning when you want to sleep or tired. But anyway, I wanted to ask, because in your presentation, you spoke more about preserving the patient and what are the parameters that we need to maintain in order to make sure that we preserve the organs while they're still in the patient. But when the organs have been harvested, do they, other than putting them on the ice, is there any special fluids that they
Yes, there are.
inject or they put into the organs just to preserve it? And also, is there any like some type of duration in terms of how long can the organs be outside of a human body? The last question is, I know you said that in your presentation that in the UK and all the other countries, first world countries, that the paramedics are pro to organ donation in terms of initiating all of those conversations with the families or with all the stakeholders. In your, I know maybe a study hasn't been done in SA, maybe there's a research project, but in SA, based on your anecdotal experience, when you had conversations with the paramedics, were they pro for organ donation or were they against it? Because I think that's something important in terms of making sure that if these cases arrive, that there is a chances that they might have potential donors.
So, okay, your first question, yes, there are specific fluids that are used to store the organs and to preserve the organs once we've done. That is an entire different lecture on its own that I can take an hour and a half to talk to you about in terms of donor procurement. But there are specific fluids that are used. Currently, we run on a cold ischemic time. Your cold ischemic time is noted in theatre. The recipient theatre is notified at the same time that we stop the heart. There's a very specific way that we do it when we're doing donor procurement from a donation after neurological death. It's very, very time constrained, and it's got to be to the minute. With a heart, you have 4 hours of cold ischemic time. Lungs, you have 6 hours of cold ischemic time. The liver, you have about 16 hours of cold ischemic time, and kidneys, you can go up to 24 hours of cold ischemic time. It's preferable that you do it sooner rather than later for the lungs and the liver and the kidneys, because the longer the cold ischemic time, the longer your graft, you have a delayed graft response. So the longer it'll take that kidney or that liver to start actually functioning appropriately and properly. And then in terms of your second question, the majority of the paramedics that I've come across are actually pro-organ donation. Maybe not necessarily for themselves, but they understand the value that organ donation offers to the general populace out there. So I think there is a platform for it, and I think there is a platform where we can open that door and have that conversation, and we can actually start those conversations. I've come across within the nursing field, within the doctor field, and within the paramedic field, there is a subset or a subgroup of people that do not believe, for their own personal reasons, which is fine, they do not believe in organ transplantation, and they obviously won't be willing to partake in that. But the greater sort of populace within the community, or the greater community, are actually advocates for it. They do believe in it. They do believe that it should be done. They do believe it's an important aspect of what we do. And I think pre-hospitally, we need to start having these conversations, because we are, in a lot of cases, and I think we're missing this prior to this, it was always, you guys are just ambulance drivers. We're not. The world is slowly recognizing that as pre-hospital practitioners, we offer a lot pre-hospitally in what we do in terms of patient outcomes overall. And we contribute far more than just putting them in an ambulance and driving them to hospital, or putting them in a helicopter and flying them to hospital. We can play a massive role in whether the patient actually has a significant positive outcome by what we do pre-hospitally. And it's not just on nursing staff and doctors in hospital. The pre-hospital has become a very large component of the medical field, and is a large contributor and a positive contributor to patient outcomes. And we can be a positive contributor, I think, to these outcomes as well. For potential for increasing donor pools if we work together. I just want to hop to Liam's question quickly. Is it possible for organ recipients to be donors themselves? At the time of donation, Liam, yes, it is. You get something that they call domino transplants. They are done. We've done a small scale domino transplant here, where we've had organs from one we've moved from one to the other to the other. We've had one patient that's required a heart and lungs, but the heart itself is actually still functional and can be transplanted into another patient. So that's then been transplanted into another recipient. Previously transplanted organs, we can do a second transplant if the first graft fails, but we cannot take that organ and use it again on another patient. Once it's been transplanted into one patient, that's where it stays. We did have an incident quite a few years ago here in South Africa. Husband donated for wife, or wife donated for husband. A few years later, they got the divorced, and the donor wanted his kidney back. And we were like, that's not how it's going to work. Sorry, your kidney's done. And the City of Cape Town has a massive organ donor program. They run out of Tygerberg, Groote Schuur. Red Cross Children's Hospital has a liver team. Tygerberg or Groote Schuur run heart, lung, and kidneys, as well as liver. And Chris Barnard runs a cardiothoracic transplant program. There is a I think I might actually have access to it. There is a list of your donor procurement coordinators in your different programs in all of the different provinces in South Africa, that you can get hold of them. And then Carl, you've had your hand up for a while.
Hi Gail, hi everyone. So this is a bit of a random question, but say now you've got an international tourist that on their passport they state they're an organ donor and they do die in South Africa. What is the process then for organ donation? Does that country where they reside from need to be contacted and go through their processes? Is there any platform or procedure that is followed regarding that?
Within my we've never had any overseas patients that have become organ donors, but it would fall under, because they're in South Africa, it would fall under South African law. So even if their passports or their states that they're organ donors, they're an organ donor, we would have to get hold of the family. The family would have to be out here. The family would have to give permission, for those organs to be donated. So it would ultimately, again, it would fall back on the family, because we're an opt-out system. So in their home country, there might be an opt-in system, but in South Africa, we're an opt-out system. Sorry, in South Africa, we're an opt-in system. So it would still ultimately, the decision would fall to the nearest closest family members that are with that patient at the time.
Okay, that makes sense. Thank you.
Okay. Mohammed? Mo? Mo's disappeared. Can you guys hear me? Did I just disappear?
No,
Joseph?
I can hear you.
Now we can hear you.
Joseph?
Yes, I can hear you. So I posted my question in the chat. It's just regarding, is there a hotline available to prompt questions and manage to see a little bit regarding that? So while the medics are busy, you don't miss any questions or just speak to the family. Is there something like that available?
Not at the moment, no. That would be something I think that we would probably have to be the driving force behind to set up with. It would be opening the door of conversation with the donor teams and the procurement teams within South Africa and opening that door and looking at setting like something like that up, looking at setting up courses where you guys, where, you know, we can say to the paramedics, this is how you approach the subject, this is what we're looking at, this is what we're looking for. So it would, you know, it's again, it would be an engagement with the role players within, you know, the procurement teams and all the rest of it. So, but at the moment there isn't such a thing. Your best bet would be like if you're heading to a hospital like Mill Park, if you're heading to a hospital like Alberton, reach out to the trauma surgeon on call or whoever you're going to on call and discuss it with them what they'd like to do, because most of them, being Mill Park, Alberton, and that, they're very open to organisation. They work very closely with the teams, so they will also identify early patients to say, listen, we've got a potential, come and call the team in early to actually start, you know, optimizing the patient for donation and all the rest of it.
Thanks for that. The reason for asking is I'm in Mossel Bay, the Garden Route side, so it's a very small, it's got 2 hospitals.
Yeah.
So yeah, that's just even the idea of organ transplant is quite foreign. But thanks.
You actually do have an you have a coordinator down there. In that area. I'm just trying to think who it is. Yeah, you have a coordinator in that area. I've done a few, I haven't done Mossel Bay, but I've done procurements in George and that. So, Tom, sir, good morning.
Hello, can you hear me?
I can. Morning, sir. Good to talk to you.
Hey, less of the sir, you make me feel old, girl. Thanks for the insights and thanks for the insights and reminding us the importance of this. I think, you know, in our busyness of treating patients at the time, it's the furthest thing from our mind, to be honest. So it's always good to bring it up, and I agree with you opening the conversation, but I want to throw a cat amongst the pigeons.
Go for it.
And for me, clearly the organ donation procurement side of things has predominantly been run on the private sector. Correct me if I'm wrong.
Within South Africa, yes.
Okay.
We have started a program in Johannesburg with Charlotte Meke. We do work closely with the Red Cross Children's Hospital in Cape Town and Groote Schuur with their they do have quite a good successful transplant program. We work closely with them. KwaZulu-Natal did not work with Netcare. I'm not too sure how they work with Lenmed now, because I think Cindy's gone across to Lenmed. But with us, when I was at Netcare, they didn't work with us. They do their program, we do our program, and they run kidneys.
So in saying that, what I'm actually going to bring up is the following. I'm a donor myself. I have been for many years. When I die and you take my organs, there's massive financial consequences and charges here. How does that work? So is there a price tag on my heart? Is there a price on my liver? And how does that get charged? And how does that whole thing work? For me, that's been a very contentious thing in my mind to understand. If you can give me some insight to that.
So there isn't a specific price tag. What they do is there's obviously the patients on medical aid. The government patients are covered by the government. So what we've done in the past, and as I said, we work closely with Tygerberg in that, is we have 2 teams. So we have the transplant team and we have the procurement team. So the procurement team they will procure the organs from the donor, and then what will happen is we will send them out to whichever area they're going to, where they've got the appropriate recipient, be it provincial or private. So across the country, there is, for those patients that are on medical aid, there is a specific fee charged, a set rate fee charged for organ procurement.
Ready? I'm sure it's Spanish. Yeah, I don't know. Azang Babus, I just send them. They're actually working. It's just that they're looking for a better.
Sorry, Tom, I muted you, but I just if Ephraim, can you mute, please? Sorry, Tom, I muted you.
No worries. I actually muted myself because I can see whoever Ephraim is needs to mute himself because we can hear what he's saying.
So there's a set fee that's charged, that's agreed upon by the medical aids. The organ, however, will go to the most appropriate recipient, be it in provincial or private. So what will happen is if we're doing the procurement in the Gauteng area, we will look at the recipients we have in the Gauteng area. If they are not, if none of them are appropriate, then we will offer the organs to the Durban team. If they don't have an appropriate recipient, then we will offer the organs to the Cape Town team, and that will be provincial and private. So there's no charge for that. And then obviously the recipient himself, if they're in private, when they get transplanted, they will pay, their medical aid will pay for the transplant itself. But there is no, if we send an organ to provincial, and it goes to provincial, doesn't go to private, there's no charge for it going to provincial. Here's your organ, you've got the appropriate recipient, go ahead and transplant it into the recipient. With regards to the transplant itself and the organ procurement, there is a set rate that the medical aids will cover from the recipient side. So there won't be any, you will pay for your hospitalization as a patient up until the point where the procurement team takes over your care. Then it switches off your medical aid and moves on to the recipient's medical aid.
No, I can understand all of that, but I think what I'm trying to bring forward is that the whole industry or the whole team, everybody's being paid, but this poor patient that donates their stuff. Do you understand what I'm saying? And I can understand from the traditional aspect and even from anybody else's aspect to go, but hang on a minute, you're going to take all these things, there's all this financial stuff, and everybody else is benefiting financially. Not that I'm saying that we should be paying for organs to the family. I'm just saying that for me has always been it's always been a stumbling block in my mind, although I am a donor myself. And I think it's a very honorable thing that we do that. But I think there's a part here that just doesn't fit, if you know what I mean. How do you change that somehow? I understand people's time and expertise, and it's a financial thing at the end of the day. I get it. But that for me has always been a stumbling block.
Yeah, so the focus is less around the organs themselves and more around, like you said, the team and that. And we have negotiated set rates with the medical aids, and then from the provincial side, the team is appointed by provincial services, and they're paid by the hospital they work for. They're paid under the government by the hospital and that they work for. So the organs themselves aren't specifically charged for. There is a charge for procuring the organs, and we take over the costs of that. We take it onto ourselves, so that the donor family doesn't have, once we take over, they've signed off the documentation to say their loved one is an organ donor, the costs shift. So it's no longer the responsibility of the family of that person that they've chosen to do. So it won't be your responsibility or your family's responsibility. Once we've taken over, in terms of the family signed off to say, okay, they're willing to donate the organs, and we've taken over, the cost shifts. So the family of that person doesn't carry any cost at all.
Okay, thank you. Got it.
Okay. Mohammed, I saw your question come through.
Okay.
Um,
How are you doing there?
good, and you, Mo?
Very good, thanks. Just for everybody to know as well, my question is, and you know, I support you 100%. My question is just, you know, from an Islamic point of view, how do you approach Muslim families? Because, you know, that would be a very, very difficult conversation to have with the family.
It is a very difficult conversation. The few transplant or the few donations we've had from Muslim families has been due to the families approaching us and offering to do organ donation. In terms of recipients, we've had recipients. There is provision within the Tissue Act in South Africa because understandably from a cultural perspective, you need to be buried with all your organs, all your body parts. We have had a couple of recipients. We've had a heart recipient. We've had one or two other recipients of organs. And there is provision within the Tissue Act in South Africa that those organs can be the organ that's removed, the organ that's being transplanted, is kept aside. Once the patient's well enough, they're released from hospital, then going through the proper process, that organ is released to them for burial, for where they will be themselves buried one day when they pass away, so that when they are buried, they're actually buried with their organ, their original organ as well.
No, okay, thank you. That answers it because
So,
you know there is you know a Quranic verse as well where you know if you save one person, you save the you know mankind. So you know that can also be looked at in that sense. But thank you very much, Gail. You have a beautiful day.
Gilbert, your question. Where is the transition from resuscitating the patient for survival to resus for organ donation? Pre-hospitally, resuscitate the patient for survival. In terms of optimizing a potential donor, I think it would be more applicable in your sort of your transfer from a facility that doesn't have the facilities to do organ procurement to a facility where they can do organ procurement. So don't change from aiming for resuscitating the patient for survival. That should be your ultimate goal regardless. If you are resuscitating the patient for survival, you are resuscitating the organs for survival. If you're not comfortable making that call or making that decision, if we've got time, I'm going to briefly go through, because there's still quite a few, I'm going to briefly go through brainstem testing with you guys. Some of it you can see on the road, you'll know what it is, you'll be able to pick it up, you'll be able to identify it. Then the other tests that are done in hospital, bearing in mind they're done by doctors. 2 independent doctors, independent of either the organ donation team or the organ transplant team. Christina, is there an age limit for organ donation?
Gail, I'm gonna sorry, Gail. I just wanted to maybe just if we can put a note that maybe we can do some brainstem stuff in a further presentation. I just think time-wise, it's going to be better to explore it in a lot of detail, if that's okay.
Yeah, the procurement in that we can do, that's a whole other lecture. It's going to take me as long. That's a whole other lecture, or longer. Okay, so does that answer everything for now with everybody? Mo, you still got your hand up. Does that answer everything for everybody for now?
Apologies.
That's cool. Okay, so the biggest mindset change that we need to see in hospital and on the road is the patient's just an organ donor. They don't need anything special. Wrong. They need a lot. When you have brainstem death, or brain death, actually it's no longer brainstem death. When you have brainstem death or neurological death of the brain, you have the development of what is called a catecholamine or a cytokine storm. This starts within 7 hours of brain death occurring, and it has a profound effect on end organs as well as the body as a whole. It can cause severe end organ damage, and it can take a patient who is a good organ donor with optimal organs and make them a marginal, if not an organ donor that we actually cannot make use of. So it leads to the cytokine storm is a massive inflammatory response with specific inflammatory pro-inflammatory markers, interleukin 8, interleukin 6. There's a few others, and it has a profound effect on end organ damage as well as graft function and increased mortality and morbidity in recipients. The lungs are the most vulnerable. They cause fluid buildup in the lungs. You see similar effects that you would see in ARDS, where you have protein leakage, you have cytokine leakage, you have that kind of damage to lungs. Lungs are the hardest to get; they're the hardest to match to recipients. So lungs are very important if we can get good lungs. The cytokine storm that we see increases your ischemia, reperfusion, induced primary graft function. So we can have the lungs fail. These patients may need to, the recipients may land up on ECMO for a period of time before their lungs actually start functioning. As I said, it can occur within 7 hours of brain death occurring. It's usually followed by frequent profound vasoplegia, hypertension, and then a global perfusion of all solid organs if not appropriately maintained and controlled. In hospital, in ICU, once the procurement team takes over, what they do, the vasopressor of choice is desmopressin, in South Africa known as DDAVP. They will give, you get it in a nasal form. They will give 1 to 2 squirts up nasally, intranasally. It's 2 to 4 micrograms, and that usually has, it has a knock-on effect.
That's a scam. It's not there. And none of these guys here is driving. It's all non-driving.
I just spoke to this guy. He says it happens all the time.
Yes, he said there was yesterday someone who came here to fetch the car. He paid 60,000 rand.
Guys, please, if you're not presenting, please mute yourself.
Hey! How do I talk now, Beck?
I'm speaking to
the vasopressor of choice is desmopressin.
Guys,
Once they've administered the
desmopressin, please mute
Does this come
yourselves.
through as cash? Does this thing come through as cash?
it says, it's fine.
I'm gonna change it.
Listen, what you can do is
DDAVP has a it actually impacts on a number of different systems, which is why it is used. It uses an intranasal spray, which is absorbed quite quickly, so it starts functioning quite quickly. It's usually about 2 to 4 micrograms that is given. It can be repeated 6 to 8 hours later if necessary. Brain dead patients often develop what we call central diabetes insipidus. It occurs into 60% of these patients or more, and this is the primary choice of drug for central diabetes insipidus. Diabetes insipidus, bearing in mind, is not diabetes mellitus, which originates from your pancreas. Diabetes insipidus is polydipsia, polyuria. You have decreased osmolarity in your urine and overall decreased osmolarity. These patients that develop this type of central diabetes insipidus, they can lose fluids of up to 9 liters. So you've got to replace those fluids, and you've got to, so the sooner you can actually get the diabetes insipidus under control and stop that unintentional fluid loss, you're going to have an easier time in terms of your fluid resuscitation and your inotropic use. It also has an effect on the systemic anti-inflammatory response, where we see that was a cytokine storm I was referring to. We see a massive upregulation in complement cytokines themselves, interleukin 6 and 8. DDAVP assists with that. The biggest use for controlling that and bringing that within controllable ranges and minimizing that cytokine storm and again your end organ damage is methylprednisolone. But we are talking doses of, we give doses up to 1 gram of methylprednisolone in hospital for these patients. So if you can, if there's a way to do it pre-hospitally, you can look at giving methylprednisolone if it's within that scope of practice for that patient at that time, if it's a drug that you can justify giving at that time within your scope of practice and within the methylprednisolone scope of practice. Obviously not at the doses they give within hospital. Also be careful giving this on the road, because what is done when we take over and the family sign consent, we draw bloods, and one of the bloods that we draw is for what we call human leukocyte antigen typing. So it's your blood groupings that you see on your white cells. Yes, white cells have blood groupings, and that's a conversation. That's a whole other lecture on its own. This is particularly important for kidney recipients and kidney donors. Your kidney recipients have a lot of HLA antibodies, so we need to match them very closely. Otherwise, we have graft failure. High-dose methylprednisolone will suppress your HLA proteins and could skew the results in HLA typing. Your steroids administration of your methylprednisolone, or prednisone, sorry, may also improve hemodynamic instability and reduce your vasopressor requirements, so you won't need as much DDAVP. Although there's no particular sort of limit on DDAVP, it can be given every 6 to 8 hours as required until you've got the diabetes insipidus and everything else under control. These patients, one thing you need to watch out for, and you could see on the road, they're a high risk for developing your neurogenic pulmonary edemas. So not ARDS, it's a neurogenic response to your hormone dysregulation that occurs within brain death. Thyroxine is a drug that's still currently given in South Africa to stabilize hemodynamics. So it is a T3, T4 replacement drug. It's a thyroid replacement drug. We see thyroid dysregulation with the death of the hypothalamus and the pituitary gland. So hence also the shift away from brainstem death versus brain death versus neurological brain death. It's not just your brainstem that dies, it's your entire brain and the associated organ structures with it. So you see, this is where you see your neurohumoral regulation go for a ball and become very dysregulated. Recent studies, however, coming out have shown that thyroxine, it doesn't seem to actually add any additional benefit to being administered to a patient who has suffered a neurological brain death. So there's some debate about whether or not it should still be given. Doesn't cause any harm, but studies coming out showing not really a benefit either at all. We do know, however, that neurological brain death will lead to profound hypothyroidism quite rapidly, which impacts a number of organs. This is mitigated by DDAVP. And as I said, recent studies are showing that thyroxine is not quite what we thought it was. It doesn't seem to actually have much of an impact on stabilization. Where ECMO comes in is ECMO can be used as a bridge to organ procurement and to preserve end organ function, particularly in your donation, if you're looking at donation after circulatory death. This is where your ECLS programs internationally come into play. France has them, the UK is initiating them. They meet patients in out-of-hospital cardiac arrest, meet specific criteria. High-end CPR, layman CPR from the outset, advanced life support within 10 minutes, I think it is, and at either ECLS at a hospital with ECLS in the ED or ECLS at the patient's side within 60 minutes with continuous high-quality CPR. These patients can then be used. ECMO is also used as a bridge to organ transplantation for both heart and lungs. Donation after circulatory death. This has come in the last 10 to 15 years. This is done, so there's two forms of death, your neurological death, your neurological death, and your circulatory death. If requirements are met for either one of those two, the patient can be declared dead. When we do organ donation on patients who've been declared neurologically dead, time of death recorded on the death certificate and official time of death is recorded as the time of the second brainstem death that confirms, or the second brainstem testing, brain testing that confirms brain death. It's not actually the time we stop the heart in theatre. That is noted, but that is not noted as the time of death. This is known as donation after circulatory death, and the patient has to fall within specific, what they call the Maastricht criteria that was developed by the Netherlands. The Netherlands, France, Belgium, and the UK actually have quite significant donation DCD programs that are running, and they're actively engaging with pre-hospital providers in terms of running those patients. There are 4 criteria that involved. 2 are uncontrolled. You get your uncontrolled donation after cardiac death. These are usually in hospital. We know the patient is terminal, but they are not brain dead, but they're going to die. So they're not entirely they're not entirely brain dead, but the outcome is going to be the same. The outcome is a terminal one. They have sufficient brain injury that they're not going, it's an unsurvivable injury. So in those cases, they withdraw, they palliate the patient, and then they wait for circulatory death to occur. Usually within these environments, the patient is actually taken to theatre to wait for circulatory death to occur. In some cases, they might prep them to start on ECMO or to start on cardiac bypass. As soon as the heart ceases to beat, they then initiate the cardiac bypass or the ECMO to preserve organ function. Uncontrolled donation after circulatory death is your out of hospital unplanned cardiac arrests and your unplanned or unexpected cardiac arrests in hospital. These patients can still be moved to theatre rapidly if they're in hospital, and the organs can be surgically removed. At the moment, although the UK has done 125 transplants on donation after on uncontrolled donation after circulatory death. So that was out of hospital cardiac arrest, where the pre-hospital providers have gotten the patient to hospital, they've activated the team, they've gotten the patient to theatre, and they've managed to harvest the organs. Across the world, internationally, what is called the dead donor rule applies. Organ procurement must not cause the death of the patient. The patient has to either be declared neurologically dead or circulatory death has to occur before these organs can be procured. So this is your Maastricht criteria. Class 1, dead on arrival, uncontrolled. Most of the time, the organs that are procurable are your tissues, your bone, liver, ligaments, your bone, skin, ligaments, corneas, and heart valves. Unsuccessful resuscitation, class 2, this will be out of hospital cardiac arrest. They can harvest the kidneys as well as the above. In anticipated cardiac arrest, controlled in hospital, all organs except the heart. However, there have been, as I said, in the UK specifically, there's been at least 125 donations in these situations where they have successfully transplanted the heart, and the recipient has gone on to survive. Where your brain donor suffers an unexpected cardiac arrest while you are prepping them to go to theatre, again, because everything's been in place, you rapidly move them to theatre, you can harvest all. Again, the heart is now being looked at as harvesting we're able to harvest it and use it. And then your class 5 is your uncontrolled, unexpected cardiac arrest in hospital. So a patient who doesn't, they're not looking at donor procurement, they're not looking at organ procurement, but all of a sudden the patient suffers an unexpected cardiac arrest. They then can get them to, if the family consents, they can get them to theatre and they can harvest all organs. We are moving towards looking to harvesting the heart as well. And then your neurological death, this has been the primary focus of organ donation for many years. It's no longer called brainstem death. It's referred to as donation after neurological determination of death. It's confirmed by a specific set of neurological exams, an apnea test, and what we call an atropine test. These are the donors that are well timed, well controlled, especially once you start procurement process. It's down to the minute, and it's intense. They will remain on life support. They will be optimized until such time as we can take them to theatre, because the recipients are then also prepped and ready. Your recipients and your donors are done and prepped at the same time, and there's constant communication between the two theatres, where the donor theatre is, where the recipient theatre is. This was a focus of optimizing these type of patients. However, a bigger role, I think, in the future is going to be seeing donation after circulatory death, where we're going to be able to get programs in place with pre-hospital providers that we can recognize these are patients that are potentially good donors, the family is open to it. And these are programs that we can start looking at to increase the organ donor pool overall for transplant recipients. So before brain death is noted, the clinical criteria for brain death, it's permanent and irreversible. It's done through a number of things. The patient undergoes CT scans, MRI scans, radio nuclide scans. In babies, they do cerebral ultrasounds. They then undergo brainstem testing, which is done by 2 independent practitioners that are not linked to either the donor team or the recipient team. One of those practitioners must be qualified for more than 5 years. They can do the brainstem testing at the same time. The recommendation, however, is with the apnea test, they only do 1 apnea test. So preferable to have both practitioners there to do 1 single apnea test because of the stress it places on the donor. So in order for brain death testing to be done, all reversible causes are ruled out. There are certain things that will mimic brainstem death. Those have to be ruled out beforehand. Sedation, analgesics, and paralytic infusions are stopped for a minimum of 24 hours if they have been on constant infusions. If they've received regular doses, the recommendation is they are stopped for at least 12 hours. If they've been receiving random doses of analgesics, paralytics, or sedation agents, that is stopped for a minimum of 6 hours. Most of the teams aim for at least 12 to 24 hours to ensure that the patients have cleared the drugs out of their system. The old school teaching would be 5 half-lives of whatever drug was administered. This was ineffective, however, because patients metabolize drugs at a different rate, and you would need to know exactly when those drugs were started and how much was given. And a lot of it occurring pre-hospitally is not recorded appropriately. So now they take it for usually 24 hours, and then they will do the brainstem testing. What they look for when they do this, patient is in a confirmed coma, they're not responsive to stimuli, there's no spontaneous eye opening, no verbal or limb movement. You may, however, see spinal reflexes. Understanding your brainstem testing or your brain death testing comes from your cranial nerves. It's testing of your cranial nerves specifically in the brain. It's not testing your spinal reflex nerves, which are learned triggers as you grow. So these become deregulated when you suffer brain death. So they can occur spontaneously without there actually being, the brain will still be dead, but you may still see spinal reflexes. And it's knowing how to differentiate between the two of them, which is an actual brain cranial nerve reflex or which is a spinal nerve reflex. And then obviously the apnea test is performed. Brain death testing includes checking pupillary reflex. Pupils are fixed, non-reactive to light. They can either be midpoint or dilated. We do not do brainstem testing on patients with pinpoint pupils or pontine pupils. There is still something in the brain alive. Corneal reflex, we open the eye, we touch the eyeball, we touch the cornea to see if there's any blink response or anything like that to the cornea being touched. Oculovestibular, oculocephalic reflex. There's some debate about these. Previously, it was known as the oculovestibular reflex was known as the cold caloric test. You inject a good 50 mL of ice cold water into the eardrum, and you see if there's any associated eye movement. Usually, what will happen if there's anything in those cranial nerves, the eyes will move to the side where you injected the water. They've moved away from using ice cold water. Water itself or lukewarm water actually works just as well and is a lot less stressful on the patient. They will do it in both ears 5 minutes apart. Oculocephalic reflex, known as doll's eye movement. You move the patient's head to the side, and there is an associated eye movement in the opposite direction or not. This is, however, difficult. This is not done as commonly anymore because you get a submaximal response to your oculocephalic reflex, and is also limited by possible brainstem damage, base of skull damage, base of skull fractures at the point where the brainstem exits or where the spinal cord exits the brain, and also C-spine injuries. Obviously, you don't really want to go you don't really want to go moving the head around, even if the patient has an underlying, even if they are brainstem dead, you still don't want to, you risk sending them into a cardiac arrest if it's a high enough fracture. Gag reflex, we'll put down a suction catheter, we'll stimulate the back of the throat, see if they have an appropriate gag reflex. Cough reflex, suction catheters pass down the ET tube to see if there's any cough reflex when that is done. Motor response, ensuring that there's no cerebral response, in other words, no cranial nerve response when painful stimuli is applied. This can be done by pushing on the orbits above the orbits, the superior orbits or the lower orbits. It does hurt. There are small nerves that run there that link to your cranial nerves. The patient will grimace or pull away if they still have any brainstem reflexes. The apnea test, very specific test. They recommend it only be done once, both doctors present. Patient will be pre-oxygenated at 100% for 10 minutes, ensuring that their CO2, their PaCO2 is within normal range or within baseline range for that patient. So they will have been monitoring PaCO2 from the time the patient's admitted. They may have their baseline may be off, and they may have an established baseline of PaCO2 of 50, PaCO2 of 30 outside the normal range, but it's been their baseline from admission. They will also look at your PaO2, your lactate, all of that. Everything else must be within normal ranges. What they will do is they will put you onto an FiO2 of 1 or a percentage of 100% oxygen for 10 minutes. The ventilator will then be disconnected, because a lot of the newer vents actually have an apnea reflex. So as soon as you switch it onto CPAP, the patient doesn't trigger the vent will automatically kick in and breathe for the patient. So what they have to do is they disconnect the vent entirely. They will put an oxygen cannula, oxygen tubing down the ET tube, down the tracheal tube if the patient has a tracheal tube, and they will let that run on about 6 to 8 liters per minute for the duration of the apnea test. What they look for is any spontaneous breathing that the patient does. What they will also do is an arterial blood gas will be done before the apnea test is started, after the administration of 10 minutes of 100% O2. At the end of the test, they will repeat the blood gas. If the CO2 has risen by more than 20% of the baseline of that patient's baseline, if they're not within normal baseline, or if the PaCO2 has risen above 60%, your apnea test is positive, your patient is brain dead. And then the last thing they will do is atropine test. They will administer 0.04 milligrams per kg of atropine. This stimulates specific receptors in the brain. If this is administered, you will see a possible concomitant rise of more than 3% in heart rate. If you see that, there is still something in the brain that's functioning. Patient is not brainstem dead.